to this webinar. On our panel, we have distinguished health experts, as was already shared with you all. The illicit trade of tobacco product poses major health, economic, and security concerns around the world, and that is why WHO's World No Tobacco Day theme is around this issue as well. We have noted tobacco control expert Dr. Ehsan Latif. He is the director of Tobacco Control Department at International Union Against Tuberculosis and Lung Disease, and has a very long inning on a range of tobacco control issues around the world. So, Ehsan, without taking any for any further time, I think I should pass on the microphone to you. Thanks. Over to you, Ehsan.
Hi, good morning, everybody, and good afternoon or evening, and wherever in the world you are. It's a great honor to talk to you, all of you, because for us, media is the most important partner in our crusade against tobacco and all the harms caused by tobacco. So I'll have two parts to my presentation. The first part is just to share some of the progress across the globe under tobacco control. And the second part, which is only a couple of slides, will take, I think, more time and discussion as it relates to the challenges that we are facing as we go forward. Bobby, can we go to the next slide?
Yes.
Just to show you the union's role in delivering health solutions in tobacco control. Union is an international organization which deals with lung health. And tobacco control is the biggest component in the risk factor which compromises lung health. And when you see it with people with tuberculosis, people with compromised lungs, it becomes even a greater challenge. So what we have been doing in the last 10 odd years now is that we have a grants program through which we offer financial and technical advice. We have a capacity building program because we think that if you want to make tobacco control sustainable, you have to build the capacity of the people on the ground. Till they understand and know what to do and how to deliver, we will not get any sustainability for tobacco control efforts. And that's why I keep saying that media is our most important partner, because even if the financing is not there, the media is there to help us say the things that need to be said and to keep the governments in check and to provide accountability. And we also work with the different cessation models, because once you have all these policies in place, where do the smokers go? Who is going to help them? So we are very concerned about people wanting to quit. On the paper it looks easy, but for a smoker who is addicted to nicotine, it is very difficult to quit. So you need to create an environment where people can quit easily. So this is just a brief overview of what the union does in terms of tobacco control. Next slide. This slide you should be looking at shows progress. The main progress in the world has been the WHO's Framework Convention on Tobacco Control. It's a huge achievement for any public health initiative, because this set into motion a set of policies which was needed to control the increase of tobacco use across the globe. And the best part is that this was the first health treaty negotiated under the World Health Organization, and also became the fastest to be ratified. And as you can see on the slide, there are more than 180 parties to the convention. Some countries, not a lot, have signed but not ratified, and there are only a few dark spots across the globe in which countries have not signed or ratified. But just to give you an example here, Indonesia has given us some quite effective laws, but it is still in the dark. And Argentina, which is in the slightly less darker area, has shown quite good progress in the laws that it has, and has got good smoke-free environment. So Most of the countries have signed and ratified. A few of them are still to come on board, and we encourage them to do it all the time. Next slide, please. Now, when the Framework Convention was negotiated and ratified, it had both demand and supply side measures included in it. But given the resources that we had, WHO came up with the Empower strategy, which was let's prioritize the demand side interventions which pertain to health, can be done in the short term, and which have the most effect on reducing tobacco use. So smoke-free was the most obvious because we wanted to save everybody from the effects of secondhand smoke. And in this slide, these are all taken from the Atlas, Global Atlas from the World Lung Foundation, and also from the WHO report on the global tobacco epidemic, which was published in 2013. Things might have changed in the country where you are coming from, but this represents the most recent published global data. Next slide, please. So what that progress really means is that there are now 1.1 billion people covered. 10 years ago, we had not even thought that we would have such a big coverage. But we have moved along in the second-hand smoke area and are protecting a lot of people from the harms caused by it. Next slide shows you the protection from smoke. Some countries in which there is no traction for the national laws, we have continued to work with the cities, and you can see a global progress in the cities across the globe. And all these X's mark are the ones which are still not covered, but you can see Beijing, but Beijing has just in the last couple of months passed the smoke-free law, which is very effective. So big, important political and strategic countries are also coming and joining us in the fight against tobacco and to save the people from the effects of second-hand smoke. The second Empower strategy was health warnings, and huge progress here because we can see a lot of countries which have passed graphic health warnings. And some countries, and now there is a growing trend of moving beyond what was required under the Framework Convention. We recently saw Australia, the United Kingdom, and France passing the generic packaging, or also called the plain packaging, though the tobacco industry has challenged it, but it is a measure which we think is going to have a dominoes effect across the globe. Recently in Southeast Asia, after India, Nepal, Pakistan have all passed legislations which is for the 85% of graphic health warnings. Nepal has even gone beyond, it is 90%. And a lot of other countries have joined in. The different colors shows the rounds because we want this to be rotational. We don't want people to get used to the same image, seeing it over and over again. So we want these to be rotational. But graphic health warnings have made a good impact on tobacco use. The next slide that you have, you must be looking at advertising, promotion, and sponsorship. Now that we have curtailed the ability of the tobacco industry to reach through the usual means of the promotion that it does, it has shifted to the corporate social responsibility angle on some of the internet, which remains a challenge. But good progress under advertising, promotion, and sponsorship bans as well. And the next slide shows you the numbers which are taken from the previous slide. So you should be looking at advertising, promotion, and sponsorship bans with some numbers on it. So there are complete bans in 24 countries, 103 are moderate. These are good bans, but more work needs to be done. And only one has minimal, while 67 have still not done anything. There are challenges here because then cross-border advertising, signals coming into the country, movies depicting brand placement, with loads of challenges, but good progress under advertising, promotion, sponsorship bans. The next slide would show you increasing taxes. We want the taxes as high as possible so that it becomes unaffordable for the young and the most vulnerable to buy cheap cigarettes. Now, people have been linking taxes to illicit trade, which is the theme of this World No Tobacco Day, because we want to raise awareness that taxes and illicit trade are not the same thing. You cannot relate uh, one to the other because on the surface there is this argument that if when you increase taxes, the cheaper cigarettes will flow in through illicit trade. But that is illicit. You know, the word has its own meaning, which is under any dictionary, it is illegal. It should be stopped. Whether you have illicit trade of an apple or an orange or any food product, it is illicit and it should not happen because then the country is losing revenues. So it should be tackled on the borders. That is why the illicit trade protocol is so important for us, because we want to take away the argument that taxes lead to illicit trade. No, illicit trade is done by the tobacco industry. There are only a handful of industries, transnationals, which manufacture tobacco, and they are the ones responsible for illicit trade, not taxes. So you need to increase your taxes as much as you can so that the poor and the vulnerable are protected, especially the youngs who are more prone to price changes and elasticities than the rich and the affluent. So this really shows, I think, my struggle and Bobby's struggle and everyone's else, and also the media. The next slide shows that we have come so far. So what is stopping further progress? Why can't we start talking about the end games? My feeling is that we are still far from that discussion. We still need to do a lot of things. We need to do a lot of strategy, a lot of planning before we can start discussing the end game. So challenges, a very simple slide, no graphs, but this slide contains in it, I think, the work for the next 5 to 10 years. As we see and as we continue to work in the social political environment across the globe, keeping tobacco control on the political agenda is very difficult. We have seen in the recent discussions as Millennium Development Goals transition into Sustainable Development Goals that tobacco on one side, keeping health there is also a challenge. So we need to continue working to make sure that any, excuse me, any global effort which is done, any global agenda which is set out, any strategy which is planned contains tobacco control. Because without tobacco control, you cannot attain these targets. And you need to give the country ambitious targets so that they can work towards it. Not targets which are achievable in the next couple of years, but to give them targets which really affect the situations on the ground. And to keep the tobacco industry away on influencing these political agendas. Article 5.3 of the Framework Convention talks about the interference of the tobacco industry and how to keep it away from public health policies. We need to expand it. We need to expand it to go beyond public health policy. We need to expand it to go into trade, into laws, into litigations, into corporate social corporate social responsibility, and to keep industry away from anything and everything which it is doing to destroy the health of the people, the environment of our globe, the agricultural issues, and the trade issues. Now, as I showed you in the different slides, countries are passing more and more laws which are consistent with the Framework Convention on Tobacco Control, but infrastructures on the ground do not support a strong implementation. A law will remain a law until it is enforced. So if you want to get the benefits out of it, countries need to implement it. And that is also a big challenge as far as I'm concerned. And in my opinion, till these infrastructures are in place, the people will not get the benefit. So if you have a law on secondhand smoke, smoke-free environments, and people continue to smoke and it is not enforced, the benefits of it do not reach the population. And the reason I put it as a challenge is that it requires resources. But we do not need to go and reinvent the wheel. What we need to do is that we need to use the existing infrastructures to make sure that these laws are implemented. There is always food inspectors, there are always sanitary inspectors, there are other people working with the ministries of health, there are district coordination committees, there are other channels in the countries that you work in. Try and explore those channels, how you can use those channels to implement tobacco control laws. There is always going to be different kind of responsibilities for the federation or the central governments and those on the local bodies which work with the people on the ground. Your community-based organizations, the civil society can be a huge resource in implementing the laws. They have always been the eyes and ears of everything that we have ever done. Media is the biggest supporter of tobacco control. It can report to the government of the breaches that are being done in the hotels, in the pubs, in the bars, and the hospitality sector. They know what is happening on the ground. They have their hand on the pulse. So while we are looking at infrastructures for enforcement, the monitoring can be done by these CBOs, civil society organizations, and the media. Now, the third challenge, in my opinion, is the availability of resources. Now, when we say resources, it is both financial, technical, and human. Under the financial resources, taxation becomes an important component. People want to have more resources for public health. We always see politicians and officials and policymakers saying, well, we want to do tobacco control, but we don't have the financial resources to implement it. The answer is right under their nose. All they need to do is have additional taxes, surcharges, contributions. You can call it whatever you want to in your own country. See what the legal environment says, and then collect that extra amount and dedicate it to public health. It has been done and proven to be effective in many countries. Developed countries like Australia have found good resource under their foundations. Thailand has done it for quite a number of years. Philippines has just done it under its sin tax measures. Vietnam has put it under its laws. And many other countries are dedicating tobacco taxes to not only fight the tobacco use, but also to fund its other public health programs, the awareness programs. There is a discussion going on how to deal with NCDs, how to fund NCD programs. Well, the answer is start taxing the industries which are propagating these products. Alcohol, tobacco, food products which are not essential, fast foods, for example, trans fats. So we need to have taxation policies so that you have the ability to collect these resources, but not only to collect, but also to plan how do you want to spend them. And tobacco control being the biggest risk factor for all NCDs should get its fair share. So I'm a tobacco control advocate, and I'll always advocate for more resources for tobacco control, as we have been working on minimum resources for quite some time now. So we have to look at taxation as a possible avenue, or I shouldn't be saying possible, as a definite avenue for raising these resources. The next challenge is introduction of new products that use tobacco. I'll leave this now because I have a next slide which shows these new products, and I'll talk to you about these in a couple of minutes. We also need to link tobacco control with development agendas of the countries. Till you put it into the mainstream policy development, it will remain a vertical, very siloed program. You need to know that it is much broader than health. It takes into account multiple dimensions, multiple ministries who deal with industries, trade, financing, agriculture, economics, social development, and everything under the umbrella of a government. So you need to broaden it out. You need to bring in your development agendas and relate it to tobacco control. Now, moving on to the next slide, we always say tobacco industry is a challenge. But the tobacco industry, we have looked at it quite conventionally over the last 10 years. We need to see what the tobacco industry is planning for the future. We cannot continue to firefight whatever the tobacco industry throws at us. For once, we need to be ready for the challenges which will be posed by the industry. And we need to start planning and thinking on how do we predict what the industry is going. And to do that, we need to have more strategies in place to monitor the industry activities. So we had the tobacco industry documents, we knew what they were thinking, but they will continue to subvert the efforts of not only WHO, but all the ministries, my work, your work, Bobby's work, CNS work, everybody who is related to tobacco control. They will be subverting the work that we do, making it less effective and finding loopholes in the things that we do. So we need to be very conscious of their presence everywhere. And the corporate social responsibility, I think there are other experts in this world who can talk better on corporate social responsibility. But for me, they have an army of lobbyists going across the world trying to influence. And just to give you an example, I'm from Pakistan. They tried to co-opt a very progressive government to subvert the 85% graphic health warning in Pakistan. They tried to use their economic argument and co-opted this highly developed tobacco control country into their efforts. So that's the type of lobbying that they do across the globe. Now moving on to the next slide, and probably the second last one, which is these electronic cigarettes and introduction of newer and newer products into the market. Again, given the experience that we have, some of the examples on the YouTube, I challenge you seriously, everybody who is on this webinar, to go on Google, just type in 3 words, electronic cigarette advertisements. And you don't need to be registered, you don't need to be 18, you just need to Google these 3 words and you will get thousands and thousands of ads of electronic cigarettes, bordering from ridiculous too absurd, too vulgar. I'm sorry to use this word, but they're obscene. This shouldn't be shown to anybody, neither juniors, not young adults, or senior. It's disrespectful. But that is what is happening. And one of their CEO says, we are trying to bring back the chick attitude, the sexiness in smoking. So we are coming back to where we were in the 60s and 70s, where advertising was common. The Marlboro man was riding everywhere, bringing cigarettes with it. And now we are looking at electronic cigarettes. So we need to make sure that one, we deal with these electronic cigarettes. But the bigger challenge here, which is that this electronic cigarettes has the potential to divide the tobacco control community. Some tobacco control experts favor electronic cigarettes. Some oppose it, that they have banned it entirely in their country, or are advocating for entire bans. Now the question comes, where do I stand? I think that it has not proven to be an effective cessation device because we don't have the clinical trials to back it up. Doing it with a very small sample size does not convince me of its effectiveness as a cessation device, so I cannot recommend it. It is for the countries to hand it over to their drug regulatory authorities and say, if you think this is a good cessation device, let's register it and use it as a cessation device, not like the one which this woman is showing in the ad where it says, dear smoking ban, we are here to destroy you. This has the potential of rolling back our programs 10s and 20s years before and take us back into the 70s. The other question that I have and I keep asking myself is, why would the tobacco industry start manufacturing a product which, in their own words, or some of the words of the people who back it up, say that this has the potential of people stop buying cigarettes and moving on to electronic cigarettes. So why would you manufacture which is a threat to you? Why would you manufacture a product which is a threat to your own other main product? So again, many questions that need to be asked, and it is a threat for the implementation. I will end here and open it up for any questions. I hope you got answers to some of the questions. I've got questions on agriculture already in place. And my response to those questions is, when people ask us, is that what are we going to do about agriculture? What are we going to do about the people dependent upon agriculture? And the response was, and the response is that we need to plan ahead. 10 years ago, we just celebrated 10 years of the Framework Convention coming into force. We said we are still a long way from enforcing the empower strategies, the demand side of tobacco control and FCTC. And we will start thinking about the supply side as soon as we make progress in the more obvious reduction strategies. Well, the time has come. The governments need to start planning of the transitions from tobacco agriculture into alternate livelihoods. What are we thinking about those people? We don't have the answers right now. We don't know which crop can substitute tobacco growing, which is on the surface as lucrative as tobacco crop. For me, tobacco crop is not lucrative, but it is the way it is presented to the growers and to the policy makers. If it was, tobacco growers would be the richest in the world, but the evidence suggests otherwise. They are not the richest, they are the most exploited people on this planet. So we need to start thinking about them. The time is now. We have made progresses under the demand side reduction strategies, though a lot of work still needs to be done, but we are comfortable in knowing what needs to be done. So we need to put our heads together and start planning for countries which depend upon whose economies depend upon tobacco growing, like Zimbabwe, like Brazil, like India. What about China? It's a growing economy, but it produces a lot of tobacco leaf. Pakistan produces a lot of tobacco leaf. So what are we thinking about it? And I think in the coming years, we need to sit down and discuss what is going to happen to those tobacco growers as we continue to work on the demand side of reduction strategies. Thank you everybody for listening.
Thank
I'm
you.
here to answer any of your
Yeah.
questions, and it's back to Bobby.
Thank you so much, Ehsan. Thank you. We will take questions perhaps towards the end. And thank you for answering the question of Peda Moyo from Zimbabwe. We already have Dr. Rishi Sethi from KGMU. He's also a panelist. He's on board, as well as Dr. Tara Singh Bam. So perhaps we will go ahead with Dr. Tara Singh Bam as per the agenda and come back to Dr. Sethi. So Dr. Tara Singh Bam, as we know, is a technical advisor to Nepal and Indonesia of the Union, and he has not only confronted the tobacco industry and done amazing tobacco control work in Indonesia, but Nepal, very sad that it faced earthquake, but it was just about to launch one of the trend-setting tobacco control policies with one of the largest tobacco pictorial warnings in Nepal, as well as the domestic laws which would have firewalled public health policy making from industry interference. So Dr. Tara Singh Bam, Tara, over to you.
Thank you, Baby. Thank you very much. Can you hear me?
Yeah, yes, Tara. Very clear.
Hello.
Yeah, go ahead.
Okay, thank you very much. I don't know how can I manage my slide.
You just say next slide and we'll move it for you. Thank you.
Okay.
Okay.
So I'm going to speak next 15 to 20 minutes about the pictorial health warnings in Nepal and Indonesia. So just next slide, sir. Yeah, next slide, please. As Dr. Ehsan says, that tobacco kills the millions of people, more than 5 million people every year, and it kills more than 25,000 people in Nepal every year, and also it kills more than 200,000 people in Indonesia every year. So what we know that tobacco is killer. So what we also know that there are most cost-effective interventions as suggested by the WHO Framework Convention on Tobacco Control, WHO FCTC. So we know that the smoker needs help. We know that we need to implement the most effective strategy to prevent youth from starting the tobacco use. So one of the most cost-effective interventions that WHO recommends, that's the graphic health warnings. And it's the key purpose of the graphic health warning is to convince a smoker to quit smoking, to prevent youth not to start smoking, and to build the public awareness, and also to support the ex-smoker to remain quitters. So these are the key objectives of the pictorial health warning, or you can say graphic health warnings. So I'm going to quickly highlight what happens in Nepal in terms of pictorial health warnings policy adoption and its implementation, and then the enforcement and the people's opinion about this. Next, please. Next slide, please. Yes. So just quickly highlight a journey of pictorial health warnings in Nepal. Can you go back? Sorry. We have started pictorial health warning actually since 2010. Until 2010, there was only text warnings in somewhere in the cigarette packs. So just it says the injurious to health. But in 2010, when the union started work with the Ministry of Health and other civil society organizations in Nepal, very quickly the tobacco industries they work with the cabinet and introduced the a 30% pictorial health warning to be implemented. But it was a really big challenge for probably all of us, especially for Ministry of Health and tobacco control advocates, because we didn't want at that time the 30% pictorial health warnings to be implemented. So our goal at that time was to to cancel this regulation and introduce a new the regulation that covers larger pictorial health warnings. That's why we work with the member of parliaments and many other civil society organizations, especially with the media group, the print media and the other types of e-media, and to cancel this 30% pictorial health warning, introduce the new one. So as a result, in 2011, the Nepal parliaments adopted a 75% pictorial health warnings. That's the big the achievements. But at the same time, tobacco industry also the challenging us in a different ways. One of the big challenge that they have done is to sue the Ministry of Health and the tobacco control advocates to undermine the 75% pictorial health warnings. So finally, it got implemented in April 2014. So you can see there is a big gap, about 3 years, about almost 30 months, the delay of implementation of pictorial health warning. I will tell you why in a second. Next slide, please. Tobacco industry, they went to the court and they put the litigation against the 75% pictorial health warnings. Their key arguments was, oh, the FCTC doesn't recommend 75%, and they said it only recommends the 30% pictorial health warning. That's their first the arguments. The second is they say the 75% pictorial health warnings this against the consumer protection law and also excise and other financial laws. And this is the space is not enough if they go for the 75% pictorial health warning. And they say this is not a constitutional. This is and the funny thing also, they say that the argument is was like a 6 months is not enough, and they need 18 months. You see, within their arguments, it's really controversial. So on one hand, they say 75% pictorial health warning is not constitutional. They don't want. But on the other hand, they say no, that the 6 months is not enough. They need 18 months to implement. So that's why they went to court and with this type of arguments. But what happens, that next slide please, the Supreme Court of Nepal in 2013, in December 2013, made a the judgments and it says that the court verdict says that the tobacco is harmful. Yes, the court recognized this based on the science, the evidence that the Tobacco Ministry of Health provided to the court. And they also, it was really interesting for all of you, is that the court said that it is the state's responsibility to protect the health and the right to health. So it means the countries can go beyond 30%, beyond it, more than 75%, even 90%, even 100%. So it's a country need. So it's a really wonderful verdict that Nepal court has made. And the tobacco control law of 2011, the tobacco industry argument is not in line of the constitutional provisions and not in line with the FCTC. And the court verdict says that it's completely in line of the Constitution and the FCTC. And then the Supreme Court orders the governments to immediately implement this the law, all the provision of the law. But what happened? Next slide, please. The tobacco is even after the court verdict from the December, and they didn't implement this until April 2014. So they tried to delay and delay. Finally, due to the media, the campaign that the tobacco control advocates made in Nepal, finally they had to implement, and they have implemented it in April 2014. Next slide, please. You can see from 2014 and it's almost nine months now, and then the Nepal governments requested especially the Ministry of Health requested to the NGO, the civil society organization, to have an independent assessment of the effectiveness of pictorial health warnings. So the Action Nepal, is the civil society organization, conducted the survey to measure the effectiveness from the people's perspectives, from the retailers' perspectives, and also to observe the implementation status at the point of sales. They did this study in January and February this year. Next slide, please. Just if you look at the effectiveness of pictorial health warning, the next slide, please. The next slide, please. Yes, more than 90% of more than 90% of the smoker and also the general people, they notice the pictorial health warning in the cigarette packs. That's the really amazing. And almost all the smoker, of course, they do smoking, and they notice this pictorial health warning in the cigarette pack. And there was someone question that whether they support the pictorial health warning. Even you can see the more than 70% of the current smokers support pictorial health warnings, and in general, the more than 85% or nearly 90% of the general public support pictorial health warning in Nepal. So next, please. Then the question, another question is how worried do you feel when you see the pictorial health warning on cigarette pack? It shows that the most, if you look at among the current smoker, even is nearly 70% of the current smoker feels really these pictures are scary, and in general, it's about the more than 80% of the participants, they feel the pictures are very scary, and that builds the really public awareness among the people. Next, please. And the effective, how effective would be in convincing a smoker to quit smoking? If you look at the current smoker, it's about more than 60% of the current smokers say that these pictures are very effective to convince themselves to quit smoking, to promote smoking. So this shows that pictorial health warning is one of the most cost-effective interventions really to convince the smoker to quit smoking. Next, please. So this is very, very interesting slide. If this question was especially asked to the smoker. The question, what did pictorial health warning make you consider quitting? So if you look at this, more than 50%, about 55% of the smokers said yes, it made them think quitting smoking. This is really, really interesting that we want. And we all the public health, the workers or the professionals wants that pictorial health warnings would be effective to convince. And then if you look at from the perspective of the current smoker, it's really effective. Next, please. Next slide, please. So if you compare here, we asked this is very interesting slide again. So 45% of the current smoker reduced the amount of cigarette smoke per day. If you look at before the pictorial health warning, before they noticed pictorial health warning in the cigarette pack, the current smoker used to smoke 11 sticks per day. So what we have found after 9 months of its implementation, they reduced the number of cigarette from 11 to 5. So this is really the useful information to convince really our policymaker and to show the effectiveness of the pictorial health warning in a really resource poor settings. So in other hands, in Nepal, the pack of cigarette, so it costs about the US $1. It's about $1.02. If they reduce the from 11 to 5, they can save really 50 cents per day. That means that's a huge amount of money for the people like in Nepal. So this slide really shows that pictorial health warning is very cost effective, and it saves out-of-pocket expenditure of the smokers, and it also saves the money for the national the economy and the social the aspect as well. Next, please. Next slide, please. So this slide shows that whether these pictorial health warnings are effective or not to convince the youth not to start smoking. If you look at the bar at the bottom, if you see if you combine the percentage very effective and effective, nearly 90% of the youth they convince that the pictorial health warning would be really effective to convince them not to start smoking. So it's as I mentioned earlier, one of the key goal of the pictorial health warning is to convince the youth not to start smoking. So we can see the results from the survey that these would be really effective. Next, please. So this is in general the how effective the health warning in reconvincing ex-smoker. The results are very similar. More than 95% of ex-smokers say graphic health warning would be very effective to reconvince them, to convince them to remain quitter. Next, please. So this is in overall is more than 90% of our respondents, the general public, they said that the pictorial health warning would be very effective to build the public awareness among the general peoples. Next, please. So here is the very interesting thing that we have asked this question to the smoker: do you still buy cigarette pack without pictorial health warning? And we found only three current smokers, they still buy the cigarette without pictorial health warning, and the majority, almost all, 99.6% say yes, those the cigarette without pictorial health warning are not available in the markets. Only they consume the pictorial health warning. What does it mean? It says that the tobacco industry claims always that, oh, the pictorial health warnings increase the illicit trade. But if you look at it from the perspective of the consumer, they don't find the pictorial health, the cigarette without pictorial health warning in the market. That means pictorial health warnings controls or eliminates or could eliminate the illicit trade market in any countries, especially in the Nepal settings. Next, please. So that's the message. Pictorial health warning is effective in controlling the illicit trade. Yes. Next, please. So the results from the retailers, just I would like to highlight whatever I have presented earlier. This is the results from the people's perspectives. So what's the opinion of the retailers? Next slide, please. Yes, we asked this question. Look at do you support pictorial health warning regulation that aims to make people's aware of the danger of smoking? 92%, 92 of the 270 the retailers, 92% of the 270 retailers said that yes, they support pictorial health warnings. It means it's always the tobacco industry argument is no, it will harm the business. The retailers doesn't want the pictorial health warning. The business people doesn't want the pictorial health. It's not. The people, they are also people. They don't want the weak public health policy, even because the business people also want the healthy environments and the support. In the case of Nepal, more than, as you can see, 92% of the retailers support pictorial health warning. The interesting question, the question second one is there any decline of cigarette sales because of pictorial health warning that we have asked to them? So yes, it's still the percentage is small, but it's significant. 35% of the 270 retailers said yes, there was some decline of in selling cigarettes because of pictorial health warning. That actually, that we public health people, we wanted this type of results. Pictorial health warning not only contributes to increase the public awareness, but also it also contributes to reduce the consumption of the tobacco use. Next, please. A result, this is observation by our surveyor at the point of sale, whether there is the effective implementation of pictorial health warning not. So if you look at this, 96, next please, 96%, we monitor 270 point of sales in Nepal. Out of 270, 260 point of sales were observed, all packed with pictorial health warning. It means almost all in a 9 months period, almost all the point of sales, I mean the retailers, they have the cigarette pack with the pictorial health warnings. Next, please. So now the question is, always there is one question, so whether if we implement the pictorial health warning effectively in the behavior of the consumers or the smokers would be changed, or tobacco industry come up with some different interference. If you look at, there is one arrow, this is in Nepali, sorry for that. The tobacco industry has distributed printed the signage to all the retailers in Nepal, and it says that if you buy buy 3 cigarettes, and you can buy in rupees 10, that is less than the 0.01 cent, I think. So it's a very their strategy is to encourage their retailers to sell the stick, the single cigarette. So most of and if you look at the impact to the consumer. Next slide, please. We asked the current smoker, did you buy a pack of cigarette or loose or stick during your last purchase? If you look at more than 77% of the current smoker, they bought the cigarette, the loose cigarette, the stick. So this is really big challenge for the Ministry of Health and for the enforcement agency. In one hand, the smoker, they switch buying the pack to the single sticks. In other hand, the tobacco industry is promoting the sale of a single stick as well. So this was the big challenge for all of us. So when we presented all the findings to the Ministry of Health, if you look at what happened next. Next slide, please. So these are the reasons. There was about 66% of the current smoker, they said yes, they do not like to see the lung cancer picture in the packs. So because of the pictorial health warning, so they switched their behavior to buy the single sticks. So we work with the Ministry of Health recently, and the Ministry of, next slide, please. As a result of this survey, the Ministry of Health is strongly convinced, and they introduced a new tobacco control regulation that bans selling loose or single sticks. So, and also the regulation, the mandates the industry to pack of cigarette at least with 20 stick per pack. And also the regulation bans tobacco industry interference. Like as I mentioned earlier, they have different the interventions, like they printed some the poster, some pamphlets, some stickers, and sent to distribute to all the retailers, saying that okay, they are promoting the sale. Different strategy, but we have the solid commitment at the government level, especially at the Ministry of Health level. So they introduced this new law. So hopefully it will be enforced effectively in coming days. Next slide, please. So, as I mentioned earlier, the Nepal government's strongly convinced with the 75% pictorial health warning, and also they are convinced to improve the size of pictorial health warnings. So, from 75% and governments increased the size of pictorial health warning to 90%. It was supposed to enforce on 15th of May, but because due to the again tobacco industry through the Ministry of Health and the governments, the case is under the review process at the Supreme Court. And not only the litigation, but also the tobacco industry joined the business group, the U.S. Chamber of Commerce, especially the lobbying the highest level of policy making body at the Ministry of Health, and also at the government level, including prime ministers. And the Indian Tobacco Company is now they housed in Kathmandu in Nepal. Every day, even this is the critical moment that we have in Nepal. The Indian Tobacco is lobbying through the Indian Embassy to the Prime Minister, to Deputy Prime Minister, even the health ministers. They are trying to undermine the 90% pictorial health warnings in Nepal. But we know that definitely we will win all these battles, and we are very much sure that Nepal will they implement this 90% pictorial health warning in very soon or in coming days. So I think I have taken a long time. So would you like me to brief on Indonesian some lesson learned, or just I stop here?
Perhaps Tara, maybe we can take some question and answer, because the time is really against us at this time in this webinar.
Yeah.
So maybe in question and answer people are ask, and maybe so we also have Professor Rishi Sethi amongst us. He's a senior cardiologist from King George's Medical University, and he is represented on several Asia Pacific and global cardiology bodies. In cardiovascular diseases, although are the biggest killer, but they seldom get their due attention, not only from the government but also in terms of programming. So over to you, Professor Sethi.
Yeah, hi, Bobby. Can you hear me?
Yes, we can hear you clearly.
Yeah, I guess you'll have to put on my slides, and then I can.
Yeah.
Yeah, hi. Good evening, everybody. This is I'm Dr. Rishi Sethi from India. At the onset, can you hear me, Bobby?
Yes, we can hear you clearly. Thanks.
Yeah, thank you. So at the onset, I would have to confess that unlike the previous two panelists and Bobby, my experience in tobacco control activities is really very limited. I'm a clinician. I'm a professor of cardiology at the King George's Medical University. However, having said that, due to my professional affiliations, I see many dreaded effects of tobacco use in everyday practice in society in general. And I can say that if you take my hospital and my small practice as a sample of what things are happening in India and Southeast Asia, what we are seeing is that almost every year we are seeing an increase in the number of patients being admitted to us, increasing to the tune of 25 to 50% per year. I mean, in 2011, the average attendance of outpatient department used to be 100 patients in a day, but now it has increased to more than 400 to 500 patients. So you can understand that the cardiovascular burden of diseases is increasing in society, and in part this is due to excessive use of tobacco also, as I would discuss. Up to 25% of my patients, and most of the patients in India, are actually younger in age group. They are less than 40 years of age, and they do not seem to be having conventional risk factors traditionally associated with cardiovascular diseases like diabetes and hypertension. But one common thread that we see in these younger individuals who present with myocardial infarctions is that most of them are smokers. So seeing this rampant prevalence of cardiovascular diseases in younger population makes me very worried towards where we are heading. In that respect, I believe that events like World No Tobacco Day are important times where we should revisit our vows to fight the menace of tobacco use and sit together to assess and replan our strategies. Can I have the next slide, please? Now, contrary to many countries where, can I have the next slide, please? Next slide, please. So contrary to many countries where the most common form of tobacco use are filtered cigarettes, in India, and I believe the situation would be similar in various other countries across Southeast Asia and China and maybe parts of Latin America, the tobacco consumption is in varied form. That is in form of cigarette smoking, that is the filtered cigarette. It is in the form of biri, which is a non-filtered form of smoking. It may be in form of tobacco being consumed with betel leaves. It may be tobacco being consumed orally. So there are various forms of tobacco uses that are prevalent in India and many Southeast Asian countries, and that I believe make the challenges of tobacco control implementation programs even more difficult, because then you have various spokes to act on in terms of control activities. So in this slide, we see that most of the countries that are major producers of tobacco are also the major consumers. For example, China is producing most amount of tobacco, and in the next slide please, we see that they are also the major consumers. But there are countries, for example, Spain, Italy, Philippines, which are not producing so much tobacco, but they are very, very important consumers of tobacco in terms of consumption is concerned. So it's really a global issue where tobacco being grown in one country is being clearly exported to others for consumption. Next slide, please. Can I have the next slide? Next slide, please. Next slide. Can I have the next slide, please? Now, yeah, so this is a little older slide, no, the previous one. The previous slide was that, I mean, this is a little older data that suggests that between 1990s, the early part of 90s and the late part of 90s, in India, actually the consumption of tobacco, both as oat tobacco as smoked tobacco, actually decreased marginally. And although I would not be too excited about it, but then it shows that in my opinion, that probably that reinforces what Dr. Tara was saying earlier, that if you put pictorial warnings, if we educate the people, if we have ongoing activities both at the government level and the non-government organization level, that we may get some positive result over long terms. Next slide, please. So right now in India, we see that still, I mean, around 20% on an average population is still consuming one or the other form of tobacco. The next slide, please. Next slide. Now, coming to the core presentation that I would be speaking, because as I told you earlier, I'm not an expert on tobacco control activities, but I can say that there are many, many consequences of tobacco use in terms of various organ systems of the body. We have effects on the cardiovascular system. Can I have the next slide, please? We have the three most commonly affected systems for in cardiovascular by tobacco are the cardiovascular systems, the respiratory systems, and the overall development of malignancies. In cardiovascular systems, the most common diseases that we encounter are the coronary artery disease, both in the terms of stable coronary artery atherosclerosis and also sudden occlusions of coronary arteries in myocardial infarctions. They both are attributable to excessive use of tobacco. Then you have cerebrovascular diseases in terms of stroke, you have abdominal aortic aneurysms, peripheral vascular diseases, erectile dysfunctions, and so on. We all are aware that tobacco consumption is associated with various malignancies, for example, lung, oral cavity, pharynx, esophagus, kidney, bladder, and as well as precancerous lesions like leukoplakia. Varied form of respiratory diseases can also be attributable to smoking of tobacco, and the most prototype of which is the chronic obstructive pulmonary disease. It also has profound ill effects on reproductive systems in terms of decreased fertility, increasing the chances in pregnancy, for example, fetal deaths and stillborns and low birth weight babies and so on and so forth. And however, the other factors, the other ill effects of tobacco consumptions are also in terms of peptic ulcer disease, periodontitis, low bone density, and so on and so forth. Next slide, please. Now, coming to the cardiovascular diseases in relation to the tobacco consumption. Next slide, please. Well, the importance of the controlling of smoking and tobacco consumption in forms of cardiovascular diseases is that there are four literally main pillars on which all the cardiovascular diseases rest in terms of risk factors, and the four main risk factors of cardiovascular disease that have been traditionally considered right from the Framingham study are smoking, dyslipidemia, hypertension, and diabetes. Nowadays, metabolic syndrome as an extension of diabetes and mental stress and obesity is also being added, but hypertension, dyslipidemia, diabetes, and smoking are four cardinal risk factors for cardiovascular diseases. And we realize that the development of diabetes or the development of hypertension and somewhat the development of dyslipidemia is more or less genetically determined. We may actually control these diseases, but there are relatively non-modifiable risk factors in terms of their development. But smoking is clearly a preventable risk factor, which is a modifiable behavior aspect, and if we can control smoking by bringing in public awareness, then we have literally controlled the 25% development of cardiovascular diseases. In that way, it's clearly the most modifiable among the traditional risk factors, and therefore it should be a major focus of our attention. Next slide, please. So we know that cardiovascular, the deaths due to cardiovascular diseases is increasing, and by 2020 it is projected that up to 41% of all deaths would be related to cardiovascular diseases, of which coronary heart disease would contribute around 23%. So if that's a huge number of deaths being contributed to cardiovascular diseases, and if we can control one very, very important risk factor, which is clearly a modifiable risk factor for which no treatment is needed, only prevention is, and prevention related to behavior changes is needed, then we would have actually solved a lot of problems, and a lot of cost in terms of both economics and in terms of social issues could be prevented, could be improved if we control smoking, and that's why these projects, these activities are important. Next slide, please. Now, this is basically how tobacco consumption leads to cardiovascular diseases. Now, it leads to activation of clotting systems, and clotting system can lead to thrombus formation inside coronary artery, leading to acute myocardial infarction. It causes inflammation in the blood vessels, which leads to atherosclerosis, and long-term atherosclerosis leads to stable coronary artery disease. It leads to a disturbed blood vessel function, coronary atherosclerosis, inflammation, all leading to aneurysms of aorta, which have got chances of rupture and producing death in a very, very sudden manner. Tobacco consumption is also associated with insulin resistance, leading to metabolic syndrome, further leading to diabetes, again contributing to cardiovascular disease in general. It leads to blood fat abnormalities. It leads to higher levels of catecholamines, which again are important precipitating causes of myocardial infarctions and various forms of acute coronary syndrome. And of course, tobacco consumption is also associated with an increase in blood pressure. So we see that among the four cardiovascular risk factors of diabetes, blood pressure, dyslipidemia, and smoking, it's actually smoking that is having harmful effect on hypertension as well as diabetes, as well as a little harmful effect of dyslipidemia also. So it can actually be a very, very common thread related to the development of cardiovascular disease, and its control may become a very, very important thread in controlling cardiovascular disease. Next slide, please. So we have talked about these things earlier. It leads to atherosclerosis, coronary heart disease, stroke, peripheral arterial disease, and aortic aneurysms. Next slide, please. So this was a study that we did way back in 2008, and it was published in Indian Heart Journal. It's an oft-quoted study in which we have seen that those patients that I was talking about earlier, the younger patients less than 40 years of age who do not seem to have traditional risk factors. Traditionally, it was considered the coronary artery disease in 70s and 80s was considered to be a rich man's disease. It used to happen to all the obese people, but what we are seeing now is it is affecting the lower socioeconomic class more and more, and these people do not seem to have conventional risk factors of diabetes and hypertension or obesities. So what was going wrong? And we tried to study it here, and we found that these people, the common thread among all these people was they were more smokers in this group, and they had higher level of high sensitivity C-reactive protein, and higher sensitivity, higher levels of hsCRP, high sensitivity C-reactive protein meant that they had low-grade inflammation going on in their body, and that low-grade inflammation potentially could be because of smoking-related activities, and this low-grade inflammation was giving rise to more atherosclerosis and more acute coronary syndrome. Next slide, please. Now, quitting smoking, we can actually decrease the development of cardiovascular disease and acute coronary syndrome by prevention of smoking. But what if the patient is already a smoker? We know that there is, of course, it is important that he should quit as soon as possible. Smokers who quit and start to start to improve their heart health and reduce their risk of cardiovascular death immediately. Within a year, the risk of heart attack drops dramatically, and even those who have already had a heart attack can reduce, they further cut down the risk of having a second event if they quit smoking. And within 5 years of quitting smoking, actually lowers the risk of stroke and most forms of acute coronary syndrome in a person who has previously been a smoker to actually a level of non-smoker. So with that, I would like to end my discussion, and I would be open to any other question related to my specialty. Thank you.
Thank you so much, Dr. Rishi Sethi, Dr. Ehsan Latif, and Dr. Tara Singh Bam. And so now we are open to the questions. So please, all of you, you can raise your virtual hand, and I will unmute you. So, or you can type in the question as well in the chat box if there is an internet issue. So there is a question for you, Dr. Rishi Sethi. The question is from a journalist from Bhopal. Raju is asking is it only smoking which is linked to CVDs or other forms of tobacco use as well?
Yeah, thank you. That's a very, very relevant question as far as our country is concerned. Unfortunately, since most of these epidemiological studies were done overseas in terms of the most classical of them being Framingham Heart Study, they have actually, many of the larger studies that are done internationally have studied only the smoked form of tobacco in form of cigarettes. But there are studies coming from the Indian subcontinent that have also clearly shown that oral tobacco consumption is also, we can't relate it to how much, we can't actually compare because we do not have that kind of data that which is more dangerous and which is less dangerous, but both smoking as well as oral tobacco is related to an adverse cardiovascular outcomes, and that has been proved by surrogate markers for a decrease in the endothelial dysfunction by oral use, increase in the erectile impotence, erectile dysfunction by the oral consumption use. So oral consumption of tobacco is, in my mind, equally bad as smoked. Yeah, I hope that answers the question.
Yeah, thank you. Is there any other question? Please raise your virtual hand, and or you can type in the question as well. There's another one for you, Dr. Tara Singh Baum.
Yes, sir.
Yeah, so the question is from Chhatra Karki from Nagrika in Nepal, and he's asking if there was, did you face any because tobacco industry would be trying to reach the politicians as well. So was it difficult for you to convince the parliamentarians to take such a strong measure?
Yes, recently, especially the Indian Tobacco Company and also the U.S. Chamber of Commerce, Philip Morris International, all the big tobacco, including Japan Tobacco, BAT, actually they are now in Kathmandu, to block the implementation of 90% pictorial health warning. Even they made the Prime Minister's Secretariat, and they met the health minister, they met the deputy prime minister, and they are mobilizing some of the member of parliaments. But what we are trying to do is, since we have the strong commitment from health minister, he completely denied the request, the arguments, and what the health minister said that he definitely will go for the enforcement of 90% pictorial health warning. There is no option. So he is ready to quit, but he is not ready to quit the 90% pictorial health warnings. And there was also a strong message when we met the Prime Minister just 2 weeks back, and the Prime Minister also strongly committed to enforce the 90% pictorial health warning. But what we need, even at this stage, we definitely need the support from media to highlight these issues. And even the U.S. Chamber of Commerce threatening the Nepal governments, if they go for 90% pictorial health warning, they might lose the international support, or at least they may lose the USAID support. That's a threat to the governments. But we know that the U.S. Chamber of Commerce is a business private organization, so it doesn't have any mandate to give this type of threats. So I definitely request all the media, including Nepal and international media, to support us in implementation of 90% pictorial health warning.
Yeah, thank you, Dr. Tara Singh Baum. And there's another question. Maybe Ehsan, Tara, and Rishi, you people can decide who will answer. It's from Caroline Tauru, and she's asking, in countries like Nepal and India, where more people are said to use bidis and other forms of tobacco like gutka compared to cigarettes, have there been pictorial warnings on these products? And the second question is there any data to show that pictorial warnings are effective?
Yes, thanks. This is a very interesting question. Nepal, the tobacco covers the pictorial health warning in all types of tobacco products, whether they are smoked or smokeless. So unfortunately, we didn't do the survey on the smokeless, but we did the survey on the effectiveness of pictorial health warning on BD. The results are almost similar. More than the 80% of the people, they said they got awareness because of the pictorial health warnings, and then the BDs. Because in our India, the Pakistan, even the Bangladesh, and Nepal, in our setting, the poor people they consume the BDs, so it's equally effective both on BDs and cigarette pack.
Yeah. Thank you so much, Tara. Is there any other question? You people can raise your virtual hand, or you can type in the question, or yeah, there is a question from Pakistan from Zishan. The question is, I belong to KPK province of Pakistan, which produces around 78% of Pakistan's entire tobacco crop that generates more than 37,000 full-time employments. Total tobacco cultivation in KPK is 36,016 hectares. That produces 93,080 tons of tobacco with value of 10.09 billion rupees. How is it possible to control tobacco industry in Pakistan? Because it would result unemployment and hit tobacco industry side. So question from Zishan, perhaps Ehsan, you might be the best person to respond to this.
Thank you, Zishan, for asking this question. I don't know how to respond to this, because this is a typical argument of the tobacco industry as well. Because if tobacco growing was so good for Pakistan, Pakistan should be a richer country than it is. And those tobacco growers in Charsadda, Sibbi, and other places should be quite rich. But this is a perception created by the tobacco industry that as we do tobacco control, jobs will be lost, people will be without work, economies will suffer, which is not true at all. So these numbers are quite big, but we need to sort out the conflict of interest in Pakistan as well, because the tobacco board is regulated by the government, and it is supported by the tobacco industry, and it is funded through the cess collected on growing tobacco. So on one hand, you are funding an organization to promote tobacco growing, and on the other hand, you're talking about graphic health warnings and effective tobacco control programs. So not only in Pakistan, in other countries, this contradiction needs to go. If you can fund a tobacco support program, tobacco growing support program through the Pakistan Tobacco Board, funded through the funds raised by tobacco growing, you should have an equal emphasis on tobacco control and remove these contradictions.
Right. Yeah, thank you, Ehsan. And Zishan, I will also like to just support what just Ehsan said, that if you look at studies done across in the region also, like in India, for example, the cost of the cost which governments have to pay to deal with tobacco-related diseases and disabilities and deaths is much more than the revenue which tobacco earns. So a study which was done in 2011 in India estimated that the total amount of the economic cost which government of India was taking care of in 2011 was about 104,500 crore Indian rupees, which was 12% more than the combined state and central expenditure on the healthcare. So to forget about comparing it with with the tobacco revenue, so it many-fold, many times more than the tobacco revenue. Similarly, a study done, I think in 1999, I may be wrong on the year, of Indian Council of Medical Research showed that the cost of treating tobacco-related cancers in government hospitals was about 5 times more than the tobacco revenues way back then. Thank you. Any further question, please? I know we are way ahead of time. Thank you so much for sticking over. But is there any other question you all people can also email us later on, and we will request our panelists to respond. Any further question, you can either use your chat functions or raise the virtual hand, and I can unmute you if the internet supports us. No, perhaps. All right. So, okay. So, Phil, thank you so much. So thanks a lot to the panelists, first of all, as well as the participants for braving these technologies and coming over. Being online, this is really very helpful, very important to connect international experts with journalists who are working on the ground. So thank you so much. We will make the recording of this webinar available, as well as the transcript, and the PowerPoint presentations will also be emailed to all the participants who registered for this webinar. There are thank you messages pouring in from the journalists from different countries. Thank you so much for all your time, and thank you to the union as well. Thank you.
Thank you very much, Bobby.
Okay.
I know.
Thanks, everyone.
Thank you, Bob.
Thanks, Rishi. Thanks, Ehsan.
Thanks.
Thanks, Tara. Bye-bye.
Thank you. Thank
Bye.
you.
Thank you. Bye-bye.